Okay, so we're going to talk about chapter 15, which is physiological and behavioral components of the newborn. Here are your objectives, so take a look at these. Some of the topics that we do talk about in chapter 15 actually come from chapter 17, so it is relevant in this chapter also. So take a look at these pages, specifically respiratory distress syndrome and hyperbilirubinemia and jaundice kind of overlap with this chapter. So the neonatal period is actually referred to the time from the birth through the first 28 days of life. At this time, the baby is referred to as a neonate. And this time period, we want to focus our nursing care is on, a lot of this is immediate, but is on maintaining body heat, maintaining respiratory function, decreasing the risk for infection, assisting parents in providing appropriate nutrition and hydration, and then assisting parents in learning to care for their newborn. So these first two specifically are happening immediately after birth. The third is ongoing, the infection. Fourth, of course, ongoing, how do you feed your baby, breast, bottle. And of course, we want to educate our parents. So the neonatal period, that's why we call it the NICU, NICU, neonatal intensive care unit. If that connects it all together now. So what we want to know is, how does the baby actually breathe once it's born, right? That miracle of life. And so this sentence here that says transition to extrauterine life, the respiratory system, the sentence in blue, the establishment of extrauterine respirations is the most critical change that occurs in the transition from fetus to neonate. So fetus is in mom, baby is born, neonate, and the establishment of extrauterine respirations, that means baby figuring out how to breathe extrauterine outside the uterus, is the most critical challenge that occurs in the transition for the fetus to neonate. Okay, that's stressed right now. I'm stressing that sentence as in learn that, know that. And so what's happening is we have mechanical and chemical stimuli sort of happening at the same time, going on at the same time. And I'll go over them separately, but I want you to understand that these two things combined is what allows the establishment of extrauterine respirations in the fetus to the neonate. Okay, so we have a mechanical stimuli. Okay, and so when the baby is a fetus, it's inside the mom, right? And it's inside the uterus, and it's floating around in amniotic fluid, right? And it's not really breathing in utero. Okay, then when it comes out, how does it really take that first breath? What makes it do that? And it has to get rid of this amniotic fluid. So to get rid of it, when you want vaginal delivery, there's loss of amniotic fluid from the lungs due to chest expansion after the delivery, and also this squeeze that happens. So as the baby is coming through the birth canal, its chest is getting really squished, and you can see this happening as it's birthing and emerging, and it's nice and tight. And once it's out, it expands, and it's going to pull air from the outside environment into the lungs and then clear the amniotic fluid. Okay, so that's kind of what this says, right? And as it pulls air into the lungs, some of the amniotic fluid comes out. You can also see it from that chest squeeze, right? Some gets squeezed out, and then you have the passive inspiration of air. Air into the alveoli replaces the amniotic fluid. When the baby starts to cry, the intrauterine positive pressure is made, and this results in intrauterine positive pressure, and a lot of that amniotic fluid gets absorbed. Alveoli remain open as the air goes in. A lot of times, you know, you want to tell parents, when the baby is born and it's crying, they're like, oh, why is it crying so much? Why is it crying? Crying is a good thing. It's actually helping the baby's wet lungs not be wet anymore. It's drying up the amniotic fluid. Okay, so crying is a good thing. It's going to stimulate that. And then on the chemical side, so once the cord is cut, okay, there's cessation of placental blood flow, right? Baby is born, we clamp and cut the umbilical cord. So when that happens, okay, carbon dioxide increases, okay, and there's no more oxygen that's getting to the baby, so the carbon dioxide will increase and the pH levels will drop, okay. So there's lack of oxygen going to the baby because the lack of oxygen as in coming from the placenta, okay, and so there's mild hypoxia. Then the CO2 increases, which leads to acidosis, okay, which is why the pH decreases. And then there's stimulation of the respiratory center. That all of this causes stimulation of the respiratory center and the medulla, okay. So the chemoreceptors kick in and cause the diaphragm to contract, and the baby takes a good deep breath, okay. And that is what stimulates respirations. That's how it's done. And then we're also stimulating respiratory center and the medulla by when we stimulate the baby to breathe by touch and by drying. So the first thing you do when the baby comes out, the very, very first thing you do is dry the baby. It's like you think of yourself when you come out of the pool. The first thing that you want to do is get a towel and dry yourself. Nobody comes out of the pool and goes, oh, this feels good to just stand here wet, right? So same thing with the baby. You got to dry the baby, and that act of drying the baby is also actually through touch. You're stimulating the baby and you're stimulating the receptors in the medulla, the respiratory center, for the baby to take a breath. Okay. And so this transition of extrauterine life that I just talked about, this internal stimuli and the external stimuli. So the external stimuli we just talked about, sensory, thermal, mechanical changes that are happening. So when the baby is born, it goes from sort of like a wet environment, right? Hot, warm inside the mom, and there's this change in temperature, right, as it comes out into extrauterine life, and that cold and change of temperature also is a mechanical change that causes that stimulates the respiratory center. So touch, sound, light, and the cold air stimulates, you see this arrow, to the respiratory center. Okay, and the chest compression during the birth draws air into the lungs, and that stimulates the respiratory center. So for those of you who like drawings and diagrams, this is sort of like a concept map of what I was explaining in the earlier slide, right? And when the respiratory center is stimulated, the infant takes its first breath. That's the external stimuli. Then in the internal stimuli, again, the chemical changes, what's happening, okay, is that when the diaphragm contracts, right, when oxygen decreases, so you start here with the PO2, PCO2, and pH. When the oxygen decreases, when we cut and clamp the cord and the baby is born, there's no more placental blood flow. CO2 increases, the pH decreases, and these changes lead to activation of the chemoreceptors, which then lead to the message sent to the respiratory center and the medulla that make the diaphragm contract, and then again the infant takes the first breath. Okay, so and when the surfactant, okay, full-term babies have this and preterm babies not so much. This is a pulmonary surfactant is a complex mixture of specific lipids, proteins, and carbohydrates, which is produced in the lungs by type 2 alveolar epithelial cells. Okay, and these cells start to mature and become mature and actually produce the pulmonary surfactant as the baby grows and matures and goes past 24 weeks of gestation, and they're pretty much in full effect by 34 weeks. We like to think that by 34 weeks the baby's lungs have pretty much matured. Okay, not fully matured, but they're there. The mixture is surface active and acts to decrease surface tension at the air liquid interface of the alveoli. So it's kind of like a soap-like substance. You can think of the surfactant that helps keep the lungs open. So lung surfactant helps to lower the surface tension in the airways, and this helps keep the lung alveoli open. And also, the surfactant has immune cells to defend against bacteria, viruses, and other infectious agents. So the presence of surfactant not only helps keep the lungs open, but the alveoli and the lungs open so the baby can keep breathing, but it also helps make sure that the baby doesn't get an infection. Okay. This is why when you call NICU, so when mom comes in and she is going into preterm labor, or we think she's going to have a preterm delivery, right? Or she's at risk for it, we'll go over it next week and the next weeks when we talk about complications. But we give the baby a medication. It's for the baby, but we give it to the mom, IM injection of betamethasone, which is a steroid, which is going to help in increasing surfactant production in the baby. Okay? So when we give this IM injection to mom, we give her a dose, and then we wait for 24 hours, and then we give her a second dose of betamethasone, and then we wait another 24 hours. And so after 48 hours of administration of this betamethasone, we're feeling a little more confident of this baby being born prematurely, because we gave it. Our biggest concern for a preterm infant is respiratory distress, inability to transition to extrauterine life and breathe. So giving the baby surfactant through betamethasone is going to help counter that. Okay, so this is why the NICU loves it. And when you call them and you say, hey, heads up, we have a preterm delivery, and by the way, the baby got its full dose of betamethasone, because they know that they're going to have a better outcome than a baby who hasn't received this medication. Okay. Now, betamethasone, by the way, can also be given to the baby after it's born, to the baby specifically through a respirator, but it's better if they get it via mom while she's still pregnant. Okay, so the babies will need to change, right? The cardiopulmonary adaptation will need to change as well. So what that is once you dry and clamp the umbilical cord, this will stimulate your cold receptors, okay? And once the baby takes its first breath, there's an increased aortic pressure and decreased venous pressure. This increased systemic pulmonary and decreased pulmonary pressure. And this causes closure of the foramen ovale, ductus arteriosus, and ductus venosus. Okay, so if we read through this, the drying or clamping of the umbilical cord and the stimulation of the cold receptors. Remember, the baby goes from warm amniotic fluid inside mom environment to outside cold environment. EPO2, decreased O2, and increased acidosis causes the baby to take this first breath. So this decreased pulmonary artery pressure, it leads to decreased pulmonary artery pressure, okay, which increases PO2, that leads to the closure of the ductus arteriosus. Okay, the decreased pulmonary artery pressure also leads to closure of ductus venosus and umbilical arteries and vein due to decreased flow. Okay, and it also leads to closure of the foramen ovale, which is the first one to close. Pressure in the left side of the heart is greater than in the right side of the heart. Okay, so sort of up until this point, here's a better visual, all right? Up until this point, the circulation to the lungs had been minimal, right? The pulmonary arterial pressure is high in the fetus. Okay, this allows the blood to be shunted through the foramen ovale. Okay, this is the circulation in the fetus. If you watch those two videos that are supplemental videos under supplemental resources, there's two videos by the Khan Academy. Okay, one of them, and I talked about this during week 1 of my lecture, and I actually gave you 2 additional videos on this, but one of them is neonatal circulation, which is what I'm referring to now, and the other one is newborn circulation, right? So before the baby is born, the pulmonary arterial pressure is high, and this allows blood to be shunted through the foramen ovale, okay? And then once the baby takes a breath, you have a decrease in pulmonary pressure, right? And blood prefers to go to the lungs because now there's decreased pulmonary pressure. Okay, so all of this leads to the ductus venosus. This blood flow stops when the cord is clamped, right? And the ductus venosus closes by day 3 of life. When blood flow stops, when the cord is clamped, okay, the opening between the right and the left atrium is what the foramen ovale is. It closes when the left arterial pressure is higher than the right arterial pressure. This closes within the first few minutes of birth, okay? Like with that first breath, the pulmonary, the arterial pressure is high, it switches, okay? The pulmonary pressure decreases with that first breath, and the foramen ovale closes. Okay, and then the ductus arteriosus closes within about 15 hours post-birth, and this is due to a drop in the prolactin level. So remember, prolactin levels are high when the placenta is there, and once the placenta is removed, the newborn is no longer does not have high levels of prolactin, and so the ductus arteriosus will thus close. It will remain open if the lungs fail to expand or PaO2 levels drop, and this is commonly seen in preterm babies, and that's why you will often hear that preterm babies have a PDA, like a patent ductus arteriosus. Okay, so once the baby takes its first breath, now you will have pulmonary pressure and closure of the ductus arteriosus, and if not, you have patent PDA. So watch those videos by the Khan Academy. They do a really nice job of explaining fetal and neonatal circulation. Okay, if you watch it once or twice, you will totally get it. So we've been talking about respirations, right? Well, normal newborn is gonna be born, and the mechanical and chemical factors are all gonna work, and the baby's going to breathe, and it's going to be great, and that baby's going to get 9 Apgars. Okay, what are signs of respiratory distress though? What about the baby that is having difficulty adjusting to extrauterine life, okay, and is going to start showing you signs of respiratory distress? What are you going to see? And this is true just like in adults, okay? You're going to see tachypnea, you're going to see cyanosis, you're going to see nasal flaring, expiratory grunting, and retractions, okay? And grunting is a sound that the baby makes when it's trying to breathe. It sounds, you don't know what it sounds like. You might hear a baby and think, oh, that's cute, it's kind of singing, but it's not, because it's going, that's expiratory grunting. It's not a good sound, okay? So The transition period for newborns when they're born to try to figure out how to go from intrauterine to extrauterine life and breathe, okay, is about 1 to 2 hours after birth. Okay, so these are babies that are having trouble transitioning, okay, and they're having trouble breathing. Okay, so that transition period again is about 1 to 2 hours, and what that means is you might see signs of respiratory distress, okay, in that transition period. What that means is tachypnea, okay, normal respiratory rate for a newborn should be what? Okay, so it should be between 30 to 60, okay? So the baby that's tachypnic is going to have more than 60 breaths per minute, okay? But what I'm saying is that during this transition period of that first 1 to 2 hours of life, you might pick up a respiratory rate on that baby of 72, okay? It's above 60, but in that first 1 to 2 hours of life, that's normal. The baby is learning how to transition, okay? And babies don't have regular breathing, okay? They're going to have irregular respirations. That's normal, okay? Again, they're in this first 1 to 2 hours after birth, that's going to be normal. It's not that normal for them to have nasal flaring and grunting, especially not retractions as you can see in this photo. But if the baby's doing it for a little bit and it's transitioning and it's during this first 1 to 2 hours of life, technically it's normal, okay? We're talking about if these signs of respiratory distress persist past this normal time frame, and now the baby is 3 hours old and I go to listen to respiratory rate and it's now 80, that's no longer normal. Now I'm saying, yes, this baby is tachypnic, okay? This baby is still grunting. It's been, doing that for an hour. The baby's going to get tired. The baby's going to get tired of using nasal flaring and its expiratory, like muscles, and you're going to see retractions. The baby's going to get tired. So if you let this persist for longer than 1 to 2 hours, that means the baby is struggling and they're going to tank on you. Okay, so you need to pay attention to it and get help if that's the case. You need to call NICU, get someone to come assess the baby. Okay, so these are signs of respiratory distress if you see them after 2 hours of life. Okay, here's a photo of acrocyanosis, which is blue, hands and feet, right? But you see the rest of the trunk of the body is pink. Here's a baby that's cyanotic, okay? Maybe at first when they're first born, the first 20 seconds or so before they take their breath, this is what color the babies are. But once it takes a nice deep breath and starts to cry and has a strong cry, within a minute when you're doing that 1 minute APGAR, the baby should pink up already. So if you keep seeing this, that baby's not staying skin to skin with mama. He needs to go to the wormer and be resuscitated, possibly, probably. Although if I was giving this baby an APGAR score, I see pretty good grimace, okay? And the tone doesn't look too bad. Okay. Respiratory distress in the baby is essentially anything that causes stress for the baby is going to lead to respiratory distress in the baby. And the most common cause of respiratory distress in the newborn and the neonate is a C-section birth. Okay, that is highlighted, and I want you to know that. Okay. But why is that? Why is the most common cause of respiratory distress a C-section? So that's because during a C-section, the baby doesn't have that squeeze that I just talked about earlier that we see that it experiences with a vaginal delivery, okay? So that squeezing effect and how I talked about mechanical and chemical factors playing a role in the baby taking that nice deep breath is not really there with a C-section baby. And so they're going to have respiratory distress, okay? So other reasons, cord prolapse, right? That's going to cause some stress in the baby. Low APGAR scores, not well oxygenated baby, stress. Okay, so again, anything that stresses the baby is going to lead to respiratory distress. Meconium staining, that means the baby was already stressed before it was even born. Premature and post-mature babies are going to be in effect. Premature babies don't have enough surfactant, right? And they're going to have a hard time breathing, thus they're going to have respiratory distress. Same thing goes for SGA babies. Is this slide cutting off some things? Maternal history of diabetes, premature rupture of membranes. For whatever reason, we don't know the exact cause, but diabetic mom babies have lungs that are slower to mature. So if the mom has diabetes, anticipate that the baby may have respiratory distress. Their lungs are slower to mature. Premature rupture of membranes, because this may lead to infection and or preterm birth, at which point then the baby is going to be stressed, lead to respiratory distress. Maternal use of barbiturates or narcotics close to birth, right? Remember, narcotics are going to cause respiratory depression. That's why we would see minimal variability in the baby's heart tones. You would pick that up on the monitor, right? So if I was having nice moderate variability and the baby was all nice and normal and oxygenated pretty well, and the mom asked for IV pain medication, I gave it to her, it is anticipated that the baby's heart rate will go to minimal variability. Okay, but if she's been using it throughout the pregnancy or close to birth, like just maternal use, and or I gave it too close to birth, well, it's a respiratory depressant. So it's going to make baby sleepy, and if it's born too soon before it gets cleared out of the mom's system and just out of the baby system, the baby's going to have trouble breathing because I gave it a drug that made it do that. So now I have to resuscitate the baby. That's why if mom is close to delivery, we don't give her narcotics for pain medication. Okay. And then if I had a non-reassuring fetal monitor strip, okay, that's all going to stress the baby out, which is going to lead to respiratory distress. Okay, so know those signs. APGAR scoring, I put the slide in here because it's a really nice review. Okay, again, you are looking at 5 things. Each letter stands for something. APGAR is actually named after the woman whose last name is APGAR, I think. And it's looking at these 5 indicators, and you're either giving it no points or 1 point or 2 points. Okay, so appearance for A is actually referring to the baby's skin color. So if the baby is blue like that photo at 1 minute of life, okay, it's getting 0. If the baby's body is pink like that other photo with the acrocyanosis, but the hands and feet are blue, you're getting at 1 point. And if the baby's all pink, which no baby is at 1 minute of life, so they'll never really have a 10 out of 10 APGAR score, you would give it a 2. But that the baby and acrocyanosis is normal for how long? Do you guys know? 24 hours, okay? After birth, once the baby's, a day old, that should have already cleared. But they cannot have any more acrocyanosis at, 10 minutes of life when I'm doing a 10-minute APGAR, and they may get a 2 for color. Pulse is the other one. If you don't have a pulse, it's absent, 0 points. If it's less than 100, 1 point. If it's over 100, 2 points. Grimace is reflex irritability. It's kind of like if I wanted to get a response and a non-responsive adult when you do your sternal rub, right? If I have to elicit a response, this is why it says minimal response to stimulation, the baby's going to get a 1. But if the baby has prompt response to stimulation, it's a 2. And if the baby's floppy, just like nothing, I'm not getting anything from the baby at 0. Grimace is like if the baby is born and crying vigorously, its grimace is already a 2. If it's grunting and struggling to breathe, you would give it a 1. So this G, the grimace, and the reflex irritability is tied in with the respiration. So if I have a vigorous cry, look at what the baby's face looks like when it is crying vigorously. It's flexed and it's grimacing. Okay. If it's like really trying to breathe, like just has kind of like shallow breathing, a little bit of like that kind of shallow, irregular, the grimace is all sort of off too. Okay, it's responding, minimal response to stimuli. And the respirations are not, by the way, you're not counting the number of respirations. It is respiratory effort. It doesn't say that here, but there's no respiratory effort as in this baby is not breathing. 0. It's slow and irregular, like I just explained, 1. And a vigorous cry, it's a 2. And the activity is the muscle tone. Does my baby have good tone? It's nice and flexed. If you pull back at its arm or its foot, it flexes it back. It pulls back. It pulls against you. That's a 2. Arms are a little flexed and legs, not fully, okay? Then it's 1, and it's absent, like you have a floppy, like a noodle, wet noodle baby, that's a 0. All right. So practice doing, I'm actually going to go back real quick, APGAR scorings on baby. Okay, either write your own questions and or there's plenty of resources. Just go APGAR test questions, and even Sarah, what's that Sarah one with the strips or whatever, she has one. But just get good at counting it. Like if I said on a test, baby is born, has good color in its extremities, but there's acrocyanosis. The heart rate is 140, and I have a vigorous cry, okay, with good tone, you give this baby a 9 APGAR, okay? Because the only thing you take off is 1 off for color. Everything else was normal. So kind of read through it and be like, what am I taking points off? That's how I do my APGAR scoring. And even when you're filling it out on the computer, you just give it 2s for everything that was normal, and you take points off for something that wasn't normal. So if my tone wasn't good, I'm taking off a point for that, and my color wasn't good, I'm taking a point off for that. I get an 8. You know? All right. Okay. Thermoregulation. This is the other key big thing that the baby has to do. It has to breathe, and then it has to keep itself not cold. So it keeps itself not hot. Okay. Physiological changes are going to happen that are going to make the baby have thermoregulation. They have to figure out how to maintain their own body temperature. Okay. Babies are homeothermic, as in all mammals are, but their brainstem is immature. Okay. And what that means is that we have to keep a neutral thermal environment for them. And what that means, a neutral thermal environment, is an environment that maintains body temperature with minimal metabolic changes and or oxygen consumption. That means like keep it neutral, right? So a neutral thermal environment for a baby would be 97.6, 98.8, because it's not too hot, it's not too cold. Because the newborn that's born has their thermoregulatory system is immature. And so newborns don't sweat when they get hot, and when they get cold, they don't shiver. Okay? Again, babies don't shiver. Okay? Again, babies don't shiver. So if I have a baby that's shivering, okay, I am concerned. I am worried about what? I'm worried about seizures. I'm worried about withdrawal. I'm worried about hypoglycemia, okay, because babies should not be shivering. So how are they maintaining their body temperature? Because that's what you do when you get cold, okay? Right. So babies have this thing called brown fat. It's a highly dense and vascular adipose tissue, okay? And they're born with it. And this little photo kind of highlights where it is in their body, sort of. And they are born with it, but once they use it, it's all gone. Okay. So, and babies really start to lay down this brown fat as they mature in that 3rd trimester of pregnancy, okay? That's why it's called non-shivering thermogenesis. Again, babies don't shiver. So their means of thermogenesis via non-shivering is through brown fat. And the factors that are negatively going to affect the baby's thermoregulation is going to be a decrease in the subcutaneous fat, okay? Like less brown fat. Well, which baby is going to have less brown fat? Okay? Preterm babies, right? Immature babies, intrauterine growth restricted babies, babies that have low birth weight, okay, they're going to have decreased brown fat, large body surface, and thin skin and blood vessels close to the skin. All of these are going to be factors that are going to affect the baby's thermoregulation. Okay, so loss of heat from convection, radiation, conduction, and or evaporation is going to also be a factor, or 4 factors that will negatively affect the baby's thermoregulation. Okay, remember this in like 7th grade science class. And so here's a slide on it. Mechanisms of heat loss, okay, can be unstable, okay, and babies, their temperature and their ability to regulate it, they're not stable, okay, it's not mature. So you want to guard against heat loss due to convection, okay. And what is convection? Convection is the cold air breeze blowing by the baby, okay. Conduction is you put the baby on a cold surface, okay. Where's the baby going? Let's say you had to take the baby to the warmer and you didn't pre-warm the warmer. You didn't turn it on before the baby was born, okay. You put the baby on that cold surface, it's going to lose heat to that cold surface through conduction, okay. Radiation, that's why we put a hat on the baby. That's why we put warm blankets on the baby. Not just blankets, you're going and getting them from a warmer, so they're nice and hot, okay. And evaporation, most people remember that, but it's when wet, right, goes too straight to the air. That's why we put dry, nice, warmed, hot blankets on the baby, and we dry the baby immediately, okay. So that's going to prevent evaporation from happening. We put a hat on the baby. It's going to prevent radiation from happening, okay. Cold breeze will close the door, turn the heater on, may have a warm environment before the baby is born, okay. Conduction, I said the baby goes on a cold surface and it's going to lose heat. Where is the best place for the baby to maintain, okay, thermoregulation? Sort of, you see it in this photo, is the mom, okay? Put the baby skin to skin. It is the best way to thermoregulate the baby. When you're weighing the baby, you have to put the baby on a scale. You take it off the mom, or off from the warmer that the warmer is on, the baby's nice and hot. You take it across the room and you weigh the baby, and by the time you bring it back, the baby has lost its heat, okay. So think about what you're doing when you're doing that and taking the baby away, okay. So also think about, remember earlier I said babies have a hard time maintaining their body temperature. So when they're hot, they're not going to sweat. Okay, so think about also the grandma with all the blankets. You walk in the room and the baby is covered in like 4 different blankets. And they're like, oh, the baby's cold, the baby's cold. Well, the baby, if it gets too hot, that's not a good thing either, okay? So you take off all the blankets and you explain, you educate the mom. But probably when you walk away, they're like, what does that nurse know? And the grandma just wraps the baby back up again. Okay, so what happens? Well, this baby's doing skin to skin, okay? When the babies are born that are extremely premature, okay, you see that little plastic bag that we put on the baby? That is instead of the warm blanket on the baby. Okay, that might be hard to do on a really premature baby like that. You put a plastic bag, they bring it from the NICU team does this, okay? And that's going to prevent any convection and evaporation in that baby. Okay, so you can see that having cold, wet baby will lead to a cascade of problems, right? All right, so when cold stress occurs, when the baby can't thermoregulate, okay, it's called cold stress. When there's a drop in the environmental temperature, okay, or in the baby through conduction, radiation, convection, right, the baby's temperature drops, okay? There's a decrease in the body temperature of the baby, and that leads to an increased heart rate and respiratory rate. So the baby gets stressed, okay? And then this leads to an increased consumption of oxygen, which is going to then deplete the baby's glucose, and it's going to decrease surfactant, which is going to lead to respiratory distress in the newborn. Okay. The baby's going to become hypoglycemic, okay? It's going to deplete the glucose. It's going to use its energy to stay warm, okay? That energy, that now the glucose is all depleted, the baby's going to become hypoglycemic, okay? And then it's going to lead to respiratory distress. So these three components are kind of tied together. Cold stress, respiratory distress, okay? And cold baby, all like kind of circle back to respiratory distress syndrome, okay? So if the baby's too cold or uses up too much of its blood glucose, then it leads to respiratory distress, okay? So actions, we already went over this, but nursing actions to decrease the risk, right? Put a hat on the baby, put the baby on mom, immediately dry the baby. But when you've dried the baby, get rid of those wet blankets and put dry ones on the baby, okay? And what are you going to do when the baby displays signs of cold stress? I mean, you want to warm up the baby. Again, I said the best place is for the baby to go is on mama, okay? But if the baby is not thermoregulating best skin to skin on mama, you might want to take the baby to the warmer under a controlled heated environment and regulate the baby's temperature that way, and frequently check, okay, to make sure it's bringing its temperature back up. All right, don't leave the baby unattended under the radiant warmer. It can get too hot. That's why a lot of times they'll just put one of those like little sticker heart thingies on the baby. It looks like kind of like an electrode for an EKG, and it is a continuous thermometer, so that if our baby gets too hot, we know. If it's not warming up, we know. Okay, continuously reads out the baby's temperature. Okay, so if I think that the baby's going to get respiratory distress syndrome, okay, is going to have respiratory distress, okay, what am I going to do? How am I going to know that baby has cold stress and respiratory distress? You're going to check for hypoglycemia in the newborn, okay? Because remember, see here, I said depletion of glucose, right? You're going to check. So large amounts of glycogen stored by the fetus during pregnancy and preparation for energy requirements after birth, okay? That's normal. The neonate then becomes independent of the mother's metabolism and must balance insulin production and glucose availability by itself, okay? Now, you're going to check the baby's blood sugar and a newborn, especially if that baby is large for gestational age, because I'm worried that that mom might have had diabetes, gestational diabetes, okay, which led to a large baby. So I want to make sure my baby is able to maintain this blood sugar. I'm going to check that baby's blood sugar. If it was a traumatic birth or a very stressful birth, like meconium stain, long labor, pushed for a long time, forceps delivery, something like that, okay, we will be stressed. Remember, stress leads to respiratory distress, which can lead to cold stress, okay? Cold stress can lead to baby having hypoglycemia, okay? So traumatic birth, preterm infant, and diabetic mom. So when we are worried about for hypoglycemia and the infant with diabetic moms, is that the mom has increased insulin, right? Throughout the pregnancy. If she's diabetic, she has increased insulin. And so does the baby. That's just what's happening. Okay. Then when the baby is born, it's still producing all the insulin as if it were getting all the sugar from the mom. Okay. Like if it's still getting all the sugar from the mom. So it's producing the amount of insulin that it's used to producing, but it's on its own now and its sugars will drop. So the baby has to figure that out. But in the meantime, it might get hypoglycemic. That's why we test babies for hypoglycemia if they're large for gestational age. Okay. So when I do a blood sugar check on a baby, usually it's defined as a blood glucose less than 40. Okay, common in transition time. Again, some of it may be normal in the first 1 to 2 hours of life, especially if the infant is from a diabetic mom, but then later the baby should be able to maintain its blood sugar. Okay. And the way we do it is we check every 4 hours, and if the baby is maintaining it after 24 hours, we say you're good. If not, then we're more closely looking at the baby. Okay. Also keep in mind that insulin is a growth factor, and that's also one of the reasons why, so gestational diabetic babies that are born to GDM moms have high levels of insulin. And I just said that insulin is a growth factor, and that's one of the reasons why high levels of their insulin makes them big. Okay, that's why they're big. Right. And so what are going to be your signs and symptoms of hypoglycemia? How am I going to know this baby's blood sugars are low? Okay, you're going to see lethargy in the baby, poor feeding, fast heart rate, jitteriness. This is your biggest indicator. Okay, this is like the hallmark sign of hypoglycemia. It's a jittery baby, and you'll see it, the shivering or the jitteriness of it in their chin. Okay. Apnea, I mean, if it's like really not noticed, but irregular body temperature. See how these are all kind of together, tied. Weak, high-pitched cry, restlessness, irritability, okay, floppiness, poor body tone, seizures, eye rolling, pale, bluish color to skin, hypoglycemia with clinical signs is a medical emergency, okay, and early detection treatment of hyperinsulinism prevents long-term neurological damage because it could lead to a seizure, right, guys? And this graph you don't really have to understand, but what it's saying is that jitteriness is like your number one sign. After that, this is kind of like the order of how likely you are to see these in a baby with hypoglycemia. So the hepatic system also has to transition, okay? Here we'll talk about hyperbilirubinemia, okay? But the physiological changes that have to adapt and take place is glycogen and blood glucose maintenance. Okay, we sort of talked about this right now. Iron storage, conjugation of bilirubin, which is the jaundice we're going to talk about, and coagulation of blood, which comes with as vitamin K is made in the gut. So the hepatic system in the newborn, in the neonate, is immature. Okay, they have an immature liver. We'll hit more on it in chapter 17, but the liver produces substances essential for clotting of blood. It stores needed iron for the first few months. Okay, that's why preterm and small infants have lower iron stores than full-term babies. This is kind of why it's important to do delayed cord clamping for these preterm babies. Because they get a little bit of extra blood from the placenta and start out life with a little bit more blood than if you immediately cut and clamp the cord. Those studies have also shown that delayed cord clamping is going to decrease the risk for intracranial bleeding for preterm babies, which is like one of the 4 leading causes of death for preterm babies. Physiological jaundice is going to come and be as a result of the mature liver in the newborn. After about 24 to 48 hours of age, it's related to the increased breakdown of red blood cells and immature liver functioning. I'm going to talk about that a little more in a minute. The yellow discoloration that may be seen in the infant's skin or in the sclera, and jaundice is caused by excessive amounts of free bilirubin in the blood and tissue. So again, babies are born with immature liver, so they're going to have a little bit of jaundice, okay? And that's physiological, okay? So I want you to understand the physiological basis of what causes this, okay? It's the breakdown of fetal red blood cells, okay? You get jaundice as a result of too much bilirubin, okay? And the bilirubin is a byproduct of broken down red blood cells, as you're going to see in a second. What is the normal hematocrit for a baby? So these red blood cells have to be broken down, right? And the baby's normal hematocrit is what? So for us, like normal adults, our normal hematocrit is somewhere between 40 to 45, right? For a newborn, their hematocrit is normal, is 45 to 65. And so then that's a lot of red blood cells, right? Why? Why do you think the baby's hematocrit at birth is so much more higher than an adult? Okay, so the hint here is like if you have a marathon runner that's training in Denver, but is going to run a full marathon here in LA, but they're going to go train in Denver. Why are they going to go train in Denver? Why is that going to make them more prepared to run a full marathon once they come back to LA? All right, and so if you're saying, well, Denver has higher altitude, okay, then when they return to a lower oxygen environment, okay, when they're used to that lower oxygen environment, they come to a place with higher oxygen environment, they're going to just do better, okay? So the same concept kind of applies to the fetus and the neonate, okay? So think about what the fetal environment is before it's born, right? It's low oxygen, right? Just like in Denver, you have a higher altitude, lower oxygen, okay? Now when the baby is born and it's breathing and it has all this extra oxygen that are now going to the baby's lungs, right? It doesn't need all that red blood cells anymore, right? The red blood cells carry the heme, the iron. So it doesn't need it to be that high anymore. So it needs to break it down. Once they're born, they don't need it. They're going to break it down. And the byproduct of broken red blood cells, okay? So the hemoglobin is made up of heme and globin, okay? The heme is going to break down into iron and the bilirubin. The bilirubin is going to get excreted. The iron is going to get recycled, okay? But the bilirubin is the byproduct, okay? And so it's excreted by the liver and feces, okay? And by about 2 weeks, okay, the baby should have figured out how to do this, okay? They should figure out how their liver works, okay, by 2 weeks. If I have a baby that's born, and remember on this slide, I said that physiological. So this is a physiological adaptation, the extra red blood cells that the newborn has as a result of being a fetus and needing it because it's in a low oxygen environment. Okay, it's born, it needs to clear it, and so as it's doing that, there's a little bit of a backup, and after about 24 to 48 hours of life, there's increased breakdown. Okay, and the breakdown is the bilirubin. It's a byproduct, right, of red blood cells breakdown. And that byproduct stains. This is the yellow discoloration that may be seen, okay? Stains the baby, it stains. That's what makes the baby's pee yellow and the poop brown, okay? So if the baby hasn't figured out how to do that, and physiological, by 24 to 48 hours, you might see the baby be a little jaundiced, okay, because this is happening. But if I have a baby that's born like this color baby, and I have a very jaundiced baby at 12 hours of life, you think that's normal? No. And I said the baby has to kind of figure out how to do this and clear out all of this extra bilirubin byproduct by peeing and pooping, okay, and excrete it out by about 2 weeks of life. So after 2 weeks, if the baby is still this yellow, then what you're concerned about is pathologic jaundice, right? Pathologic sounds bad. Something is wrong with the baby's liver, okay? So clinical jaundice detected before 24 hours of age. Okay, I said this in OBCCC. There's pathologic and physiologic jaundice. There's a rise in serum bilirubin by more than 5 milligrams. Okay, the serum bilirubin, when you check it, it's more than 15. You don't necessarily have to memorize these numbers, okay? But they're gonna have clay, white-colored stools. This may be a nursing assessment, and or dark urine staining the clothes yellow. Okay. And if you just check their direct bilirubin, it'll be more than 2 milligrams at any time. So this is a rise by more than this much per day. And these numbers will make a little bit more sense when I move to the next slide. Okay, but you have to realize that a baby born with jaundice before 24 hours of life, this is a pathologic jaundice. And you need to investigate to find out what the cause is, because treatment is required in the form of phototherapy, okay? And if you don't do that, you're going to have bad outcomes like kernictures, okay? So before 24 hours, and it persists after, oh, this is 7 days. I think it's supposed to say 14. The bilirubin increases. This is kind of what was on the previous slide, more than 0.5 milligrams per hour. It peaks at greater than 13, okay? And it's associated with anemia or Rh incompatibility, isoimmunization, ABO incompatibility. So you're going to do a Coombs test on the baby, okay? A Coombs test looks to see if this incompatibility is happening. It is tested on the baby's blood. Okay, and if it comes back positive, then you may have found the reason behind the pathologic jaundice, okay? And then if it's not treated, I said it can lead to bad outcomes. So you can have kernictures, which is bilirubin encephalopathy. Okay, so much of it builds up that it goes to the brain, and it can result from untreated hyperbilirubinemia with the bilirubins higher than 20, and it's going to cause some mental retardation. Okay, so here's the same thing that I kind of talked about in a two-sided chart. Physiological is normal. It appears after 24 hours. Pathologic before. Okay. Try to fill out a chart like this. Make a blank one and fill out each side and figure out, like, if right. There's an increase. I don't know what that was. More than 5, the increased bilirubin and a pathologic jaundice, okay, is more than 5 on this side, and the physiological is less than 5. Okay, clinically, it's not detectable after 14 days. So physiological jaundice, it's normal in the baby, especially by day 3, as the baby's liver is maturing and the red blood cells are being broken down, and there's higher levels of bilirubin, which is the byproduct. And then it figures out how to do this and excretes it all out because it's eating every 3 to 4 hours, and it's peeing and pooping 6 to 8 diapers a day, and by 14 days it's all cleared out. Okay, so it disappears without treatment. Pathologic jaundice, you have to treat it. It persists after 14 days and needs treatment. Okay, so some risk factors for hyperbilirubinemia are going to be increased red blood cell breakdown. And what's going to cause increased red blood cells, even more than what I was like normal physiologically that I just talked about? Cephalohematoma, so for whatever reason I have blood, right? Baby's skull. Maybe a vacuum was used, right? Extensive bruising from birth trauma. Okay, maybe she pushed, maybe there was a traumatic birth. Okay, Rh or ABO incompatibility, ineffective breastfeeding and dehydration. Why do you think this is? Right? So the baby is not getting enough food, and it's not going to be peeing and pooping. enough, right? And so if it doesn't pee or poop, then it can't get rid of the bilirubin. And then you're going to see hyperbilirubinemia. Certain meds may be a risk factor. Okay, maternal enzymes in the breast milk are fairly uncommon. Okay, so the baby that's being exclusively breastfed, okay, that baby that's feeding well and excreting well, it's not going to have too many physiological signs of jaundice. But sometimes babies that are exclusively breastfed might be at risk for physiological jaundice, okay? Sorry. Versus the baby that's being bottle fed, okay? Because sometimes the baby that's only from the beginning that's being breastfed, is there milk present at day one or immediately after birth? No, right? We have the colostrum, which is very low amount, right? Remember I said you only need like 2 to 3 drops, right? The size of the baby's stomach is the size of a marble. You don't need that much. So there's not a lot of volume when you're exclusively breastfeeding until by like day 2 or 3 of life when the mom's milk comes in, okay? But formula fed babies are actually getting a little bit more volume, and so then they're more likely to pee and poop, and they're more likely to excrete out the bilirubin, right? To get it out through pee and poop. So if you have a baby that they may be concerned about, they may supplement with formula to help if the baby really isn't getting enough breast milk and there's like really an issue with milk production. Otherwise, it's physiological, it's okay, it will go away on its own. So you want to talk to parents and educate them that, you know, the risks and benefits of exclusively breastfeeding actually outweigh the, you know, physiological jaundice that we know is normal in the baby. Okay? So, but just know that exclusively breastfed babies will technically be more at higher risk for developing hyperbilirubinemia than the baby that's born and is being given a bottle right from the beginning. Okay, so jaundice, how do you assess for it as a nurse? Okay, and how do we treat it? Did I skip that slide with the transcutaneous assessment? Sorry. No. Okay. Sorry. All right. So how am I going to know if the baby has jaundice? The skin is going to be yellow. Yeah, there's a tint to the skin, the sclera and the mucous membranes. Okay. And jaundice usually starts at the head and moves down. Okay. And you want to note the time of the jaundice so that we can differentiate between physiological and pathological. And the treatment is going to be early feedings, right? To get it out, to get rid of the bilirubin. Phototherapy, and in very, very rare cases, exchange transfusion. Like if I've gone to pictures like I was talking about and I'm going to have brain damage. Okay, so one way you can test for it that's non-invasive is the transcutaneous method. Okay, so it's this machine or whatever, I guess the machine, it's a handheld thing, and you press down on the baby's forehead and the chest 3 times, beep, 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 and then it takes the average of that recording. It does a thing with how much yellowness is really in the, sorry, hold on, how much how much yellowness is really there, and it gives you a reading and a recording, and then you can know if the levels are high or low. Okay, it gives you a bilirubin level. And depending on the hospital policy, they may choose to feed the baby, they may choose to do a heel stick, because direct blood, okay, is going to give me a more accurate reading level than the transcutaneous, okay, and they may choose to do phototherapy as a treatment, or they may choose not to do anything and just say, oh, the levels are okay, we're just gonna, encourage more frequent feeding. You don't have to memorize these numbers, but do understand that it is plotted, and depending on different hours of life and how old the baby is, the numbers will vary. Okay, so if I have a baby that's 12 hours old and I have a bilirubin level that's 10, right, that's not normal for a baby. Okay, that's high, and that baby would be diagnosed with pathological jaundice, right? But if I get levels of 10 when the baby is 48 hours old, that's normal, okay? So it changes, okay? So what are you going to do as a nurse? And by the way, these transcutaneous ones, but the nurses who are working in the nursery are really, really good. They can just look at a baby and be like, oh yeah, that baby needs to have its bilirubin level checked. Just by looking at a baby, they get really good at kind of figuring out what these numbers are going to be. But you still need to test it and get a diagnostic number. Okay, so our treatment is going to be phototherapy, which involves shining fluorescent light from the Billy lights on bare skin. It's a specific wavelength of phototherapy of light. This wavelength of light is going to help break down the bilirubin into a form that the body can excrete through the urine and the stool. It breaks it down so it can be excreted more easily, okay? So, the fluorescent light helps break down and makes it excrete easier. And we can do that through kind of like a Billy blanket like this baby has, or we have to put the baby under Billy lights and actually shine the ultraviolet light on them. I'm going to go back to the slide for a second. Okay, what are your nursing actions? I highlighted this for a baby who is getting phototherapy, okay, for hyperbilirubinemia. What do you think your nursing actions are going to be? And some of it, if you just look here, you'll kind of know. This baby's eyes are covered, okay? And then as much of its skin is exposed. So you want to cover their eyes. The ultraviolet light can cause damage to the eyes. Okay, but then we want to expose as much of the skin because that's where the fluorescent light is going to shine, and it's going to break the bilirubin into a byproduct that's easier for the baby to excrete. Okay, so expose as much skin as possible, but then realize that when we do this, okay, you have to measure the baby's temperature. Okay, make sure that the baby has an adequate amount of fluids. Okay, so we're not giving it water if this baby's exclusively breastfed or anything like that, but you got to check the temperature and make sure your baby is not getting dehydrated. And what would be signs of dehydration in a baby? Sunken fontanelles, okay, tenting. All right, so you got to make sure the baby's getting the correct phototherapy in the right way, but then is also maintaining its body temperature. Remember, babies that are going to get too hot, right? That's why I'm checking this baby's temperature. It's not going to be able to sweat, and it's going to shiver, and then it's going to get hypoglycemic, and it's going to lead to cold stress and respiratory distress. So you got to remember that cycle and make sure you don't start it. So Transition to extrauterine life, what is involved in the GI system, okay? Physiological changes that are occurring is that the stomach and the digestive enzymes are, growing, and there's digestive enzymes as the baby feeds, okay? There's bacterial colonization once the baby starts to eat. So when the baby is born, their stomachs are essentially sterile, right? There's nothing in there. There's no bacteria. They haven't eaten any food. And the baby's gut is sterile. Okay, so when the baby's born, we want to give them, one of the newborn medications is vitamin K. Okay, we give that to babies within the first hour of life, ideally. Why do we do it that early? And so you need to understand that babies don't produce their own vitamin K. Okay? And where's vitamin K produced? It is made in the gut. Okay, remember I said the baby's gut is sterile. So vitamin K is going to start being made in the baby's gut. Okay, physiological levels are going to go up by around day 8. When the baby has eaten, the breast milk has come in, and then vitamin K is then starting to be produced. Before then, the baby doesn't have it. That's why we have to give it to the baby. Okay, vitamin K is important for blood clotting, right? And babies don't have it, they could essentially be bleeding, right? So this is important too because, when you think about, well, day 8, how do we know that? Okay, the Jewish tradition, when they do brisk for the baby, right? That is when they circumcise the baby. And they don't do it in the hospital, okay? They do it when the baby is 8 days old because by then the baby is making its own vitamin K and we're not concerned for clotting anymore because it will be able to clot because it has vitamin K. Vitamin K is a clotting factor, right? So breastfeeding is going to prevent good bacterial colonization in the gut, and babies that are not going to have vitamin K yet, okay? That's why newborns need it. Okay, so let's move on to hemorrhagic disease of the newborn is a coagulation, disturbance, and newborns due to vitamin K deficiency. Newborns have low vitamin K stores at birth. Vitamin K passes the placenta poorly, so babies don't have it when they're born because it doesn't pass through the placenta. The levels of vitamin K in the breast milk are low, okay? So they're not getting it from breast milk. So when moms say, oh, I don't want the vitamin K injection, I'm breastfeeding my baby, that's not true, okay? They have to breastfeed the baby, and then once breast milk gets into their gut, which is now no longer sterile, the gut flora has not yet begun to develop, but it will by day 8, okay? Because that's how vitamin K is produced, by bacteria in the intestines, okay? So intestinal peristalsis, characteristics of stools, okay? Meconium is what's going to happen initially. So what do babies' poop looks like, okay? And then you're going to have transitional poop. I have a photo of it here, okay? You have meconium on day 1 to 2. And then we have this transitional poop, which meconium poop is very dark, black, tarry, sticky stuff. Then we have transitional, which is like a little bit green. And then a healthy breastfed baby stools are going to be light green and a little bit of seedy. And you want to make sure to tell mom that that seediness is okay, right? How long? Okay, and the baby's poop is black, tarry, and black like this is because it's old red blood cells. Okay, that's what's in the baby's poop. Okay, how long does the baby have to poop? So when a baby's born, you want to document that. But by how many hours of life am I going, something's wrong? Okay, about 24 hours. About 90+% of babies will have a poop by 48 hours of life. So technically you can wait that long. But if a baby hasn't pooped really by the first 48 hours of life, then essentially, by the first 24 hours of life, I'm going to get concerned. I'm going to have to tell someone. I don't want to wait till 48 hours to say, hey, by the way, okay? But technically up to 48 hours, the meconium, by 48 hours, it will come out, and then it transitions to transitional poop. Okay. And the other thing I want to note, which is on the slide, is that is there a difference between breastfed and bottle-fed baby poop? And the answer is yes, right? So breastfed baby poop doesn't really smell. Okay, it has a distinct smell, but it's not supposed to smell like shit, right? And then bottle-fed babies, poop does smell. Okay, there's higher nitrogen levels from like the formula and the cow's milk, and so that's what causes the smell. So no stinky poop and stinky poop. Okay. All right, so we're gonna move on to transition to extrauterine renal system. Okay, the kidney function is also a little immature in the baby, but their bladder capacity is only 6 to 44 milliliters. Okay, their fluid requirements in life are 60 to 80 milliliters. Okay, so they're going to pee it out quite frequently. Urine output 1 to 3 milliliters per hour. Okay, so you want to carefully monitor the baby's eyes and nose, make sure they're not dehydrated. Okay, and you're going to look at the appearance of their urine. It should not be that dark, right? And signs of dehydration or increased intracranial pressure. So if I want to know if my baby is dehydrated, I'm going to check the fontanelles. If they're sunken in like here, okay, that's a sign that you have dehydration. If I have bulging fontanelles, that's going to be a sign of increased intracranial pressure, and it might be related to my renal system. Okay. All right. So transition to extrauterine life, the immune system. Babies have an immature immune system. Okay. They do acquire some active humoral immunity, passive immunity from the mom during pregnancy. It's slow to build. Okay. And so they are at higher risk for infection. Make sure no one's coming to visit your baby. If they are sick, ask them. It's not that rude, okay, to please come visit you and your newborn when they are not sick, okay? All right, baby has senses, right? Taste buds are immature in the baby, but they can taste sour and bitter. They do prefer sweet. They don't taste salt for several months, okay? And so milk, I guess, is not salty for them. Their hearing and smelling is actually very developed. Both of these senses are well developed at the time of birth, probably have been since the second trimester. Okay, there's lots of studies done that show if you give a baby, like you've separated the baby from its mom, and you introduce the breast pads that mom has had from different moms, they can smell out which one is their mom's breast pad. Okay, highly developed smell. The infant is learning about their new environment through all their five senses. They're going to, that's why I put everything in their mouth. But they're feeling in touch. By the end of the 8th month of the prenatal development, nearly every part of the body is sensitive to heat, cold, pressure, and pain. So babies do feel pain. We'll just talk about pain assessment in a second. And they feel touch. That's why they like to be hugged and cuddled and soothed. And their sight is not the most developed. Their vision is the least developed, but at birth, the infant can clearly focus on objects within a distance of 8 to 12 inches. And so it's not surprising that when a mom holds the baby in a cradle position while she's breastfeeding, her face is about 8 to 12 inches away from the baby, okay? It's like biologically designed that way. The ability to see color develops over time, beginning with the brightest and boldest colors. All right, so baby's skin and tegumentary systems. Birthmarks, okay, they're going to be born this. Hemangiomas, okay? This, if you look at this picture, okay, vascular tumors of the skin, but at birth it's not so obvious, and by 2 weeks you can see it more, and by 8 weeks it's very pronounced, okay? Erythema toxicum is your newborn rash, okay? And it starts to develop most starkly obvious at 2 weeks of life. And this, unfortunately, is right when you are taking baby pictures and want to share them with everyone, okay? The stork bite, the nevus simplex, okay, is normal. It's benign. It's a cluster of pigmentation that will go away on its own, okay? Also, the erythema toxicum will also go away on its own. There's nothing you can do except just let it resolve on its own. And then the milia is unopened sebaceous glands. They're tiny little white pinpoint papules on the baby's nose. Usually, again, don't pop those, don't do anything. They will go away on their own, okay? This is a newborn rash. Here we have Mongolian spots, right? Hyperpigmentation. It usually disappears by school age. What's important here is you're going to, depending on the coloring and the race of the baby, you may or may not see these. Okay, common spots are on the buttocks, maybe on the leg, like that, around the ankle, along the back, maybe the shoulders, okay? What do you need to document if you see one of these? Okay, you need to document the location, the size, and you want to show the parent, right? You want to say that it's not bruising, that it didn't happen at birth, okay? You want to make sure the parents know about it and it's documented in the baby's chart so that if they do come for a visit, you're like, yep, I know that that's there, and you're not going, oh my gosh, I have a baby that may be being abused by its parents or some other care provider or whatever, right? So it's documented and everybody knows. That's the important thing. Skin color should be pink on a baby, okay? So here, cyanosis is modeling. Acrocyanosis is normal, but this baby here, again, cyanotic baby, right? Look inside the mucous membrane for signs of how the baby has good color or not, just like you do for adults. Hyperbilirubinemia is a yellow tone in the skin. The sclera will often be yellow also. Pallor is just like a dusky baby, usually caused by anemia. It's not necessarily a good sign. Blood loss, blood incompatibility, internal bleeding. So if you see a pale baby, it's not good. And the sign, it is also normal. It's immature circulatory system where like the dependent side of the baby will turn red and the other side will stay like a normal color. And this can then also switch off. So if I put this baby on its other side, that becomes the dependence and it's going to turn red, and then the other side's going to turn white, like normal skin color. This is benign, okay? It'll go away. Doesn't last forever like that. Okay. So exam of the newborn, I'm not going to go over this in detail, but there is a video on it and supplemental video sharing. And then also your book does a very thorough job. But just understand you start general observation, plus this is in ATI skills. There's multiple videos on YouTube about this, but get used to it. And you've already might have been checked off in clinical on how to do a newborn head to toe assessment. You start off with a general survey. What are you looking for? Like read through this, very intuitive. Then you do the head, neck, chest, abdomen, i.e. head to toe, hip, genitalia, anus, limb, spine, and the cranial nervous system. Those are your reflexes, okay? So for your reflexes, again, I'm not going to go over these. You should learn which ones are which and how to elicit them. Importantly, the moral, what does it mean? What do these reflexes mean? Okay, I want you to know that. So normal newborn reflexes indicate what? They indicate an intact central nervous system, okay? Same as it is for med-surg patients. But just know that babies have different reflexes than patients in med-surg, and know what they are. And You don't have to necessarily memorize them, but understand that they're going to disappear at certain times in their life. And if they persist, then that wouldn't be normal. Okay, here's a little photo of some of them. But also, when you do your assessment, you're checking for hip dysplasia. Okay. And what you're going to do is also perform the Ortolani sign, where here's the photo of it. When you're rotating the hip here, okay, it says you're going to either hear a cluck, okay, or a click. I don't know if you necessarily hear it, but you definitely will feel it, okay? And what it is when the infant's spine and knees are flexed and hips are abducted, a click is heard or felt. There's a malformation of the hip due to imperfect development of the femoral head, acetabulum, and or both. So they're not fitting properly, okay? And most of the time they're assessed at birth because we assess for it. Okay, we do the Ortolani, and then you turn the baby over, just like in this photo, and you're comparing the gluteal folds. Okay, they should line up. This little gluteal fold, you see this baby's butt cheek, and that butt cheek, they're even. Okay, and all these little rolls on this thigh, it should line up with all the other rolls in this other thigh. If it doesn't, something's off. Okay, there's hip dislocation. And then also, obviously, you're going to see shortening of one of the legs and or lengthening of the other leg. Okay? So, positive Ortolani sign. And one leg's longer than the other one. Your gluteal folds don't match up. You have a hip dislocation. Okay? How are we going to assess the gestational age of the baby? Okay? Why do we want to know the gestational age of the baby? Why is this important? Right? You're thinking, well, she comes in, she's telling me she's 39 weeks, she's 39 weeks. But, well, what if her dates were off, or she didn't get natal care, or they did an ultrasound late because, I don't know, maybe she was a teen mom and she had the pregnancy and she decided to go see a prenatal provider at 7 months when she really was showing, and that's when it was absolutely necessary. So her dates are probably going to be off, and like, what if she doesn't remember her last menstrual period, right? So her dates are going to be off. And remember, ultrasound by dates in the third trimester is going to be off by as much as 3 weeks. Okay. Or she's one of those people who says, I didn't know I was pregnant, but then all of a sudden comes and has a baby. And we want to know, well, how many weeks is this baby? Is it 35 weeks? Is it 41 weeks? And so what we do is gestational age assessment. And there are, again, supplemental videos on this, but Dubowitz neurological examination is done, and the Ballard maturational score, which is a physical and a neuromuscular assessment. That's what I have the photo of here, okay? And that will tell you if you have an SGA baby, small for gestational age, AGA, which is average for gestational age, and an LGA, which is a large for gestational age. These babies all have actually the same gestational age. Like, for example, they were all born at 38 weeks. Okay, this baby is normal, so given that it should be 38 weeks, this is what it should look like. Even though this baby is supposed to be 38 weeks, it looks way bigger. And again, this baby is supposed to be 38 weeks, but it looks so much more smaller. So that's a small for gestational age baby. And the way we assess this is we're going to look at neuromuscular maturity and physical maturity, and then we're going to give each category a score. You don't need to memorize the scores here, okay? But let me tell you what you do need to know. We give it a score, and then you add it up. And then based on what you get here on the right-hand side, like if your score adds up to 35, okay, that means that the baby is 38 weeks gestational age. Okay, again, you don't need to memorize the scores or how it adds up or what. But what I do need you to know, okay, you need to be able to score a baby, okay? You don't need to score a baby, okay? It's actually hard and it's a learned behavior, but I learned like traits, something. Once you see many babies, you're like, yeah, this is what I'm giving this baby. You know, like arm recoil is 100 to 140. But if you haven't done this on many babies, you're like, I don't know, maybe it's 90 to 110, okay? So what I need you to be able to do is if I give you some assessment findings, you should be able to tell me if the baby is preterm, term, or post-term. Okay, so I'm going to go through some of these. I'm going to give you an example so you understand. Understand that babies so the lower the score, the more preterm the baby. Okay, their posture is not going to be good. They're not going to have good tone. Their central nervous system is not as developed. Okay. For example, the neuromuscular assessment is a little hard. So when I give you, but understand that premature babies, okay, they're really, really flexible. Okay. Which one's more flexible, premature or term? Okay, preterm babies are super flexible. Term babies are pretty rigid and they have way more tone. So understand that concept. Term babies are more rigid, they have more tone. And premature babies are super flexible. They don't have as good of a tone. So if I have a baby that's born at 28 weeks, I might not give it a 2 for tone when I'm doing my APGAR, right? But if I have a baby that's born at 38 weeks, I'm going to give it a 2 for tone because I'm anticipating that that baby has grown, matured, and has better tone. This is the one that's a little bit easier to understand. Your physical maturity. Okay, if you look at a baby's skin, super preterm baby is going to have sticky, friable, transparent, okay, skin. As it matures, the skin becomes a little more smooth, okay, but the veins are still visible, okay. As the baby becomes even more mature, the skin's going to start cracking. You may start to peel in certain places, and you're not really going to see any veins, okay? And a baby that's like really post-mature, going to have deep cracking, okay? Leathery, cracked, wrinkled skin. That's a post-mature baby. Like a baby that's born at 42 weeks and 3 days might have this kind of skin, right? But understand the transition. Again, lanugo. This one's a little funny, but no lanugo is super preterm baby, right? As the baby matures, actually it has a lot more lanugo. Most abundant is between 27 weeks to 32 weeks of gestational age. Okay, look up the exact number in your book. But and then as it grows, it starts to thin out. You'll only have like bald areas and then mostly bald by the time the baby is term. So if I have a super hairy baby and I'm trying to figure out how many weeks gestational that baby is, like lots of lanugo, probably 28 to 32 weeks. If I have no hair, not a little bit even on the shoulders or the back, maybe a pretty term baby, okay? The plantar surface, you're looking at the bottom of the baby's soles. Is it like super smooth, baby barely has any wrinkles, or are there creases all over the entire sole? Same thing for breasts, eyes, ears, looks red, and the genitalia. So read kind of through this and familiarize yourself with what happens and what does the baby look like as it matures. Okay, so if I were to give you one of these characteristics and said, if the baby has full areola, you know, that's 5 to 10 millimeters, what kind of baby is it? You think it's a term, preterm, or post-term baby? You should have like an idea of that based on the description. Okay? All right, so then what you do is, remember I said you take that number and you get a gestational age. What you're supposed to do with that gestational age, depending on the height and weight of the baby, okay? So if I have the weight, I'm going to take it, can't see the bottom part over here really well, but oh, you can look at it up here. If I have a baby that weighs 3,000 grams, okay, and it was 40 weeks, okay, do your basic math, right? Somewhere right here. 40 weeks, that's an average gestational age baby. So basically, you take the number of weeks and the weight of the baby, and you come up with the little, right? And if it falls in the middle, the baby is AGA, average gestational age. If it falls over the 90th percentile, it's LGA. Below the 90th, like below the 10th percentile, it's SGA, small for gestational age. How do we assess pain in the newborn? Okay, they do feel pain. So what would be a source of pain? You know, like I'm giving it that vitamin K shot, or they're the babies have nonverbal cues, right? Just like that patient in the ICU who's nonverbal, so is your baby. It's not going to tell you, wow, ouch, that really hurts. But if you look at it, you should be able to assess the baby's pain level. Just like look at these faces, right? Okay, so we give it a NIPS score is for premature infant pain profile. Okay, sorry, that's the PIPP. That's for premature babies. And the neonatal infant pain scale is called a NIPS score. This is what I'm used to giving because I have mainly term babies, right? And you look at these factors based on the facial expression, its cry, its breathing, its arms, legs, and alertness, and how it's responding to pain, and give it a score. And then generally after you give it a score, you have to also chart what your assessment was. So if you gave your baby a NIPS score of 8, then you swaddled or you did skin to skin with mama, you're supposed to say what your intervention for the baby's pain is. Okay. Let's talk a little bit about substance abuse. Okay. Heroin and other opioids, including methadone, okay, can cause significant withdrawal in the baby, with some symptoms lasting as long as 4 to 6 months. And seizures may also occur in babies born to methadone users. Okay, marijuana use is linked to babies with lower birth weight, central nervous system effects of lower language and memory scores are seen in moms who are smoking marijuana while pregnant. Okay, I don't know why it's doing that. Ooh, how do I fix it? Anyways, symptoms, okay? You should know what the symptoms of these babies are, okay? Oh, sorry. See if I go next. If no, sorry. I don't know how to fix it. Oh, technical difficulties. Let me see. Show view controls. No. Oh, maybe this. Okay. Ew, I think I got it. Okay. So know what the signs and symptoms are if this slide is being blocked, okay, as it shows you that actually there's been a increased rise in opioid use in moms, right? But I underline the most important ones for your signs and symptoms of withdrawal that a baby is going through. One of the key ones is going to be a high-pitched cry, very different than a normal baby cry, okay? These babies also are not going to be jittery, okay? I'm going to pause the recording for a session. Ah, okay, I don't know where that went, but hold on. I'm going to share my screen as I don't know what happened to my PowerPoint. Hold on. We're almost at the end, guys. There's like 3 more slides left. But let's see. Share application screen. Here. Okay. So withdrawal symptoms in these babies that are using heroin and other opioids is tremors, okay? Irritability, so excessive crying. They're just not very easily consolable. They have sleep problems because they're irritable. High-pitched cry, like I said. Tight muscle tone, okay? These babies are going to be hard to cuddle and swaddle. They're really, really tense. They have hyperactive reflexes. They may yawn, stuffy nose, sneezing. Those are signs of their like coming off of this. Vomiting, signs of withdrawal. Diarrhea. I was in the NICU the other day and that baby had diarrhea within 10 minutes. We changed the diaper 4 times. Okay, and it had just been fed. They don't do well. They're vomiting, diarrhea, it's withdrawal. Dehydration from all the vomiting and diarrhea, they're at risk for it. Seizures, okay, from the tight muscle tone and the hyperactive reflexes. And then poor feeding and sucking. Again, they're really irritable. They're just not doing well. So key nursing action here is going to be social services, okay? But I want you to note that under these withdrawal symptoms, we're not listing a lethargic baby. And you might think that that's a sign and symptom of withdrawal, like a drugged out baby, right, is going to be lethargic, but they're not. They're actually the opposite, okay? They have a lot of irritability, a lot of tension, a lot of tight muscle tone, okay? They're not lethargic. Or they have hyperactive reflexes, okay? That kind of goes with the seizures. So know the signs and symptoms of this, because one of my favorite questions the ATI likes to ask is, what are signs and symptoms of withdrawal in a baby of a mom who was addicted to methadone, right? Or opioids. And they may say, what are the signs and symptoms of a baby who has respiratory distress, or a baby that has cold stress, right? Or a baby that has problems thermoregulating. Those 3 things are tied in together. And some of those signs and symptoms overlap with these signs and symptoms, but there's a clear difference. So know the difference between those two. Okay, so abstinence syndrome, not clearly defined, but symptoms appear about 2 to 3 days after birth. Okay, and it's associated with stimulant effects, right? Again, irritability, hyperactivity, tremors, high-pitched cry, excessive sucking, abnormal auditory brainstem responses, and ECG. For cocaine and methamphetamine exposure, these babies are at premature birth, and placental problems are what you're going to see, and even fetal death. Increased chance, okay, of SGA, IUGR, low birth weight, decreased head circumference. So these babies are going to be small because they're having a hard time growing. Probably they're also having placentation problems, right? That was here, premature baby and placental problems. So I don't have good oxygenation going to the baby as a result of the drug use. Long-term effects are real and sad for these babies. They have behavioral, cognitive skills, and physical dexterity problems. I gotta go back to my screen to advance the slide. Okay, so drug abuser mom for these abstinence syndrome babies, okay, irritability, withdrawal process. Understand there's a process, okay? Refer to table 17 through 12 for drugs that cause withdrawal symptoms, okay? In addition to the specific difficulties of withdrawal after birth, problems in the baby may include but are not limited to the following, right? Poor intrauterine growth, seizures, premature birth, birth defects. I kind of went over that in the previous slide. And then what's your nursing care for these babies? These babies suffering from withdrawal are irritable and often have difficult time being comforted. But still, this is your big goal for them. Swaddling may help comfort the baby. Babies all may need extra calories because of their increased activity, right? They're all the extra muscle and the tremoring and the tone and the rigidity is going to have them using up energy, right? They may need a higher calorie formula, which is, they're not going to be good feeders, remember? They're going to vomit, they're going to diarrhea. So they need whatever we can get in them to be of a higher calorie. IV fluids if the baby becomes dehydrated or has severe vomiting or diarrhea. So sad. So do not administer Narcan to the baby. Notice that this is written in red here, okay? Well, we really try not to give it to moms either, right? We can do a toxicology screen on the newborn, collect their urine. It's a little difficult, but we can collect it. Okay, how about mom? Do I have to get her consent, you think? Okay. she came into prenatal care and signed a consent for prenatal care, technically you can do it. But if she's coming into L&D and I have to do a drug screen test on her, I need to ask her. And most moms will give you consent, especially if say, like it's for baby, I need to know so I can best take care of your baby. They will let you know. So you want to use neonatal abstinence scoring tool every 3 hours. And you definitely want to, again, social service referral, okay? Social services will be your best friend. Fetal alcohol syndrome, we already covered this in week 1, okay, when we talked about genetics and intrauterine growth and alcohol use during pregnancy. Remember, it's the most commonly used substance, illegal use. And alcohol use in pregnancy has significant effects on the fetus and the baby. So review some of the symptoms that you would see, right? Deformities of the head and the face, heart defects, a lot of times these babies have, intellectual disability. They're going to have the short nose, underdeveloped jaw for them, okay? And newborn behavioral characteristics. I put this slide here because it's very important, guys, okay? Take a look at the periods of reactivity for the baby in your textbook, the new edition, on page 467, okay? And the reason I want to stress this is because this initial period, right when the baby is born, okay? The periods of reactivity are right. There's 3. Right when the baby is born, it's in the initial period of reactivity. And what that is that's in the first 15 to 30 minutes of life. Okay, if you look at the certain characteristics overall, okay, there's a lot of things that are being described, but this baby is awake. It's alert, okay? 467. I'll open it up real quick right now. Okay, it's awake, it's alert, okay? It's transitioning, so its respirations and heart rate may be off, okay? This is the best time to breastfeed the baby. This is why the baby needs to go skin to skin on mama, okay? Because this is when it's most awake and most responsive, okay? This is the best time for mom to bond with the baby, for the baby to attach to mama, okay? And then after that, the baby goes kind of into this like sleepy state, okay? And that is the period of relative inactivity. So about 30 minutes to 2 hours of life, okay? And the baby is really sleepy at this time, okay? And they're kind of unresponsive to external stimuli. So that's why you'll notice after the end of that golden hour when baby's on mama, say it didn't breastfeed or it might have breastfed, right? They kind of like they just fall asleep and you try to do the rooting reflex, not working. You're trying to see if they have a suck reflex, not working. They're not really responsive. They go into this like deep slumber sleep. That's normal. It's normal physiological, okay? The respiratory heart rate may decrease, okay? It may even fall below normal range as opposed to in the initial period of reactivity it was a little high. Dr. Masuda, please call 2299. Okay, and then the second period of reactivity happens after the baby is 2 hours old to 8 hours old of life, okay? This again, the baby wakes up, okay? They wake up and they're a little more responsive to external stimuli. Again, their respirations and their heart rate may be a little off, but it should be more stable than it was in that initial 1 to 2 hours of transition, right? This is important because when we stress about when mama needs to do skin to skin and when she needs to breastfeed, she really needs to do it as soon as she can. And or if she doesn't do it as soon as she can and she's trying to do it at 1 hour of life and the baby's not responsive, then she needs to understand the baby is, it's normal for the baby to be in this inactive period. And she might need to just wait until the baby is ready and giving cues of readiness for breastfeeding. Okay, the BNBAS characteristics are used to assess neonates that have neurobehavioral. It's assessing the neurobehavioral system and it's not routinely performed on a healthy neonates. Okay, I just want you to be aware, like know it, or at least have read that. So not read it, but like if you see the Brazelton Neonatal Behavioral Assessment Scale, realize that it's being used to assess neonates' neurobehavioral system, but in general, if I have a normal, healthy baby, I might not need to be assessing its neurobehaviors, okay? So just normal nursing care for a neonate in the first 4 hours of life. Okay, universal precautions. Obviously, we want to make sure the baby is safe. And what that means is that staying with its parents, right? We are tagging the baby, making sure that armbands all match up. Okay, we want to maintain body heat, right? We talked about this. Dry the baby immediately, keep the baby warm, ideally skin to skin on mama. We want to support the baby's respiration. So look and make sure the baby doesn't have any nasal flaring, no retractions, no grunting, everything is fine. The baby's color is okay. Keep them skin to skin. Okay, Apgar score, obviously you're going to do that in the first 1 and 5 minutes of life. Keep doing vital signs essentially every 30 minutes on the baby for the first 2 hours. You want to identify bands. I said that already. Neonatal assessment, you're going to do a head to toe. Gestational age assessment, make sure it matches. You're going to be ideally in the first hour of life giving the baby eye ointment and the vitamin K. The eye ointment is for what? It's to prevent infections in the baby, okay, and blindness that can essentially be caused by gonorrhea. A lot of people say gonorrhea and chlamydia, but it really is from gonorrhea. And then you do the vitamin K, we already talked about it, to make sure baby's not bleeding. They don't have that because they're not feeding yet. Okay, bath, I put a little asterisk here because I don't agree with the first 4 hours of life. Okay, you want to bathe the baby with neutral pH soap, but different hospitals will have different policies as in terms of when you can bathe a baby. A lot of them won't let you bathe until the baby's at least 4 hours old, some places until 12 hours old. Babies do have certain receptors and smell receptors on their hands that they use to help them guide them and help them be successful at breastfeeding. Okay, and so if you wash that off, I feel that they're not as successful, right? You want to promote parent-infant attachment. So what are we going to do? Do skin to skin. Encourage dad to do skin to skin. Encourage mom to hold the baby. Be aware of your environment and how you may have a bad birth outcome or a stressful delivery that may impede with this, and try to fix it, right? And that's it. That's all I have for now. Okay. The rest of the chapter, which I didn't cover, right, has the newborn assessment. I want you to go through it. There's a lot of pictures and explanations for why we do what we do, okay? Kind of know how many wet and stool diapers we need, right? How to do the neonatal assessment. It's broken down by area, looking at, like, just read through each box and kind of understand why we're doing what we're doing, okay? What normal findings are, so then if something's abnormal, you'll know, okay? So yeah, look through that, know how to do an assessment, and what your normal findings are, okay? Normal characteristics in a baby. A lot of the skin stuff I talked about is here, okay? Reflexes, all here. All here, guys, okay? All right, good luck. Let's stop that.